All right, well, we're going to get started because I'm sure there's going to be lots of questions at the end. So welcome on this cold December day, and delighted to see all of you. Before I get started, just a reminder that after grand rounds, Dr. Paauw is going to be, we're having a more informal session in G152. G5 152, which is around the corner. And so everyone is welcome to participate. And I'm sure you'll be excited after the talk today. To do the introduction, we're actually, this is a whole UW connection. I always have to, it's like UW versus UW. And we'll have Dr. Zach Goldberger in the Division of Cardiology to be doing the introduction. Before I hand it over to Zach, I also wanted to highlight our artist of this month is Dr. Shika Jha in the Division of Cardiology, who is, there she is. Woo! So Shika is a third-year fellow who's going to be an interventional cardiologist doing a fellowship in Michigan. And we're delighted to have her artwork to auction off or at the end, so stay tuned. You know, her focus has been sketching, and really it's a beautiful statement of her passion for art. So thank you, Shika, for everything that you've done for us, and I'm delighted to highlight your work. As a reminder, if you are a hidden artist, please let me know, and we will be delighted to feature you at a future grand rounds. Whether it's photography, or we can do baking, or we can do piano playing. We're trying to figure out how to do the musicians in the department. It's a little more challenging. We have some musicians and writers. We'll think about something for that. But in the meantime, please don't be shy. Love to highlight some of our residents. I know you've got amazing talents hidden away. So with that, I'm going to hand it over to Zach.
So thanks, Lynn. So it's actually it's a pleasure to introduce, first of all, to congratulate our first fellow artists in residence. The inaugural, we'll have to have more of my fellows come and show their stuff. But I want to introduce one of my favorite people on the planet. This is Dr. Doug Paauw, professor of medicine at the University of Washington and the holder of the Rathman Family Foundation Endowed Chair for Patient-Centered Clinical Education. He's actually from the Midwest, and I found out last night he's lived actually all over the world, but he went to school in undergrad in Minnesota, went off to Michigan for his medical school, which is how we sort of forged a connection there, and was actually at the top of his class there. Went off to do his residency and chief residency at University of Washington afterward, and since joining the faculty in 1988, he's become a cornerstone of medical education and clinical care in Seattle, and was a long time attending a physician at both Harborview and University Medical Center. His contribution to internal medicine education are extraordinary. He actually directed the medical clerkship for decades, actually only a couple of years ago, and chaired national committees, president of AOA, and is won almost every teaching award that we actually have to offer at the University of Washington. At the same time, he actually has international expertise. He actually brings in students from Japan and rural Japan and goes out there to sort of foster their education as well. He actually was elected to mastership of the ACP, which is actually a really coveted and rare thing to do. I was reviewing his CV. I was struck by the fact that he's got a huge breadth of scholarship, over 170 peer-reviewed articles, more than 30 book chapters and edited volumes, and countless pearls of the month and myths of the month that we see all the times in our mailboxes. He is a real gift, and I know this firsthand, for distilling complex clinical issues into practical, patient-centered guidance. Beyond his scholarship, again, he has a sort of an international footprint, and I think that overall, for his clinical issues, his expertise spans ambulatory care, sarcoidosis, pharmacologic therapy, HIV, and medical professionalism. His leadership has shaped countless generations of physicians, and you'll do so today. Today's topic, the busting the medical myths, when dogma is the dogma, when dogma is not for the dogs, is a natural extension of his decades-long work, dismantling misconceptions and bad behaviors and clinical inertia in medicine through this widely read Myth of the Month series. I've had the pleasure of teaching alongside you at audiences like this, and it's just a formative experience for me. And as you'll be doing here, I'm sure it will be for the audience. So please welcome me in Dr. Doug Paauw for Grand Rounds.
Thanks so much, Zach, for that warm greeting. Is everybody able to hear me okay? I'm a bit hard of hearing, so questions really loud, and I'm very sensitive to that. So I really appreciate getting the opportunity to, let's get this up. Okay, anyway, I really appreciate getting the opportunity talking on one of my very, very favorite topics, which is, I call it medical myths, but it's really, we're taught things that are absolutes, and the world is not absolute. Eventually, we find many ways to do things. And one of the things I love about internal medicine is there are many paths to the right answer. There isn't always one answer for everything, and that makes internal medicine such an incredible specialty to practice. But in our training, we're often taught this is the way to do it. And when we're taught something in our training, we hold on to it so firmly. So that's pretty much the idea behind this. What I'm going to start with is I'll talk with a few myths that our patients believe that I think many of us don't. And then I'm going to move on into some of the ones that we were taught that maybe we still, I hope there's something in here that will illuminate something for somebody here. So the first question is, why do these things occur? And there are several paths I've seen that lead to some of these myths. One of them is we learned physiology and we learned one way it could possibly happen through physiology, and we can't think of any other possible way, so that it doesn't make sense if something would happen that didn't work through a physiologic system we learned. A very common one is case reports. Case reports can get into literature and they don't need the same scientific rigor to get in there. A person says, hey, I saw this. Maybe you should watch for this in the future. It gets referenced a bunch of times, and after it's referenced a bunch of times, it becomes the truth. And then very commonly is things that have never been studied. It's just tradition. Since the very beginning of time, we've always done it this way. So those are some of the threads that lead to some of these things. So let's pop into a few myths that our patients believe. How about this one? I don't want a flu shot because it gives me the flu. Anybody ever heard of that? I don't want it. I only had it once and I got the flu that year. Or I got it right afterwards, I got the flu. And is there data that shows this isn't true? And of course there is. And there are some beautifully done studies. This is a wonderful study, 1,800 individuals over 60 randomized to get flu vaccine versus saline. Patients completed a questionnaire 4 weeks later. 23% of vaccine recipients versus 14% of placebo had adverse reactions. And the whole difference was it hurt more if they got the flu shot. Local effects, more tenderness at the site of the injection, 17.5 versus 7.3% of placebo. But more importantly, the flu-like symptoms, systemic side effects, 11% of those who got the vaccine versus 9.4% of those who got placebo. So looks like there isn't a difference there. But this next study I love because it's such a beautifully done study, a randomized placebo-controlled double-blind crossover trial. So everybody got saline and they all got flu vaccine. So 336 got either saline or trivalent influenza vaccine, interviewed for side effects, and after a 1-week washout period, they got whatever they didn't get the first time. So everybody got both. And then they compared what their symptoms were when they got saline versus the flu shot. And again, the only difference is more of a sore arm after the flu shot. So the whole thing of it gives me this systemic symptoms that I think are flu, no different than if you give them placebo. How about I can't have a flu shot because I'm allergic to eggs? Anybody have that? Yeah, my clinic still asks. I still go, why are you ask? If we're going to give them the flu shot anyway, you're just going to piss them off if you say, are you egg allergic? Well, we don't care. So don't even ask them. Don't do that. So where did this come from? Well, it made some sense. You know, all these things make some physiologic or theoretical sense. And then it's interesting when you actually look at it, you say, well, it doesn't happen, or it rarely ever happens. For this one, the idea that because influenza vaccine can be grown in eggs, maybe just the most minute amount of egg protein can be transferred over, and somebody who has a horrendous allergy, getting even a minute particle could trigger a severe reaction, potentially anaphylaxis. Makes sense, understandable why people worry about that. But there have been multiple studies that have looked at this and groups of people who have gotten this and what happens to them. The first study was a study in children with egg allergy confirmed with skin testing. 27 of them had a history of anaphylaxis or very severe reactions. None of them had severe reactions with the vaccine. 4 had a little bit of abdominal symptoms, and they couldn't prove whether or not that was related to it, but they weren't sick with it. So including 27 anaphylactic patients didn't have a problem. That's a small study, isn't going to change anything. When you look at all the studies out there, 28 studies, 4,315 patients with egg allergy who received egg-based influenza vaccine, 656 had anaphylaxis history with egg ingestion. None of them had a serious side effect. This was enough information that led to the Academy of Allergy to come out with this statement: all patients with egg allergy of any severity should receive inactivated influenza vaccine annually using any age-appropriate method, and you can give it anywhere. You can give it in a pharmacy, you can give it in a doctor's office, wherever you want to give it. When they first brought this out, they said they really should get it in the allergist's office, and then their offices got clogged with people coming in to get flu shots. They said, forget it, anybody can give it. We're not seeing anything bad happen here. So really, this isn't a contraindication to flu shot, and you can use any form you want to give them. This is one that's been around a long time. The vitamin C prevents colds, and Linus Pauling was the person who wrote a lot about it. He actually wrote a book about it, and he published some articles on it. In 1971, after he'd written his book back in the late 60s, he had something in the medical literature, a summary of 4 relatively tiny little published studies of vitamin C, and concluded that vitamin C supplementation helped prevent and lessen colds. And he'd done this book, Vitamin C and the Common Cold. So pretty much everybody believed vitamin C was the answer. And if you don't want to get colds, you just take a lot of supplemental vitamin C. Now, interestingly to me, the one study that he didn't include that he thought was a trash study was the one I actually liked. I mean, it was a study that, you know, it actually looked like some form of science. You know, the other ones are kind of, I don't know, have any of you read studies from the 50s, 40s? You really should. It sounds like 4 people at a bar, you know, just bullshitting. You know, it's just like, you just read it, you go, really? This isn't a scientific method. Anyway, this one actually, they did things in a reasonable way. I don't know how they found these subjects who wanted to be abused, but 91 subjects, 47 got 3 grams of vitamin C per day for 3 days before inoculated with multiple viruses, a mixture of rhinovirus, influenza B, and B814 virus. And for 6 days after inoculation, so they got the vitamin C and they watched them. And then they had people who did placebo and just got this horrendous amount of virus inoculated into them. And incidence of colds was only 6% less for the ascorbic acid group, 18 of 47, than for the placebo group, and this was not statistically significant. His argument was, well, yeah, but they got inoculated, they got a big viral load, so maybe that doesn't work for that, but if people just get it naturally, it might work. So he didn't like this study, but I liked it, except I don't understand how people would agree to be inoculated with 3 different viruses. A Cochrane review of 29 trials over 11,000 patients pretty much showed that the relative risk was crossed 1, it was 0.97. So this was not significant. So this is for prevention of colds, taking a daily vitamin C. there is some data on people who have colds if they take high-dose vitamin C. Some subgroups may have a slight improvement, a half a day improvement, but that's not fully accepted. But I just want to be clear that it's the prevention of colds where we have more data, and I think it's pretty clear it doesn't prevent colds. Now, this is just weird. And I'm hoping none of you have had somebody pee on you if you got a jellyfish sting, but this is out there in popular. How many of you have heard of this? Yeah, I mean, it's out there in popular culture. And so for some people, they're out and they go, oh my God, there's only one thing I know what to do here. And urine is not good for jellyfish stings. And this has been studied. This is a study looking at the discharge of nematocysts with different treatments. Seawater is probably about the best thing out there. Just, it's kind of where those nematocysts on the jellyfish live, and they don't go off all the time in seawater, so that may be reasonable as a neutral thing. Fresh water is bad, and urine is basically fresh water. We may not think of it as fresh, but it's very dilute, right? So it's got a lot of water. And so fresh water is that way. Urine, you can see, is pretty much the same type of number. Alcohol doesn't work. That's another thing people will try because they think, what the heck, alcohol, just throw it on anything, it will kill it. That's really a problem. Cider vinegar in this study looked to be pretty good. It's been restudied and it's not a real panacea. A Cochrane review of this from several years ago basically said the data is not good for anything, but fresh water, urine isn't useful. If you had to pick something, salt water is probably the best thing, and warm salt water is better than cold, but not with a lot of data. But definitely, we shouldn't be telling people to pee on jellyfish stings. Okay, we're going to move on to some of the myths that we've been taught in medical school, in our residencies, from our colleagues, and just go through some of these. First one is, a 32-year-old man is diagnosed with Giardia and prescribed metronidazole. He has no other medical problems. He will be the best man at his brother's wedding tomorrow. What advice should you give him about alcohol use at the reception? Do not take metronidazole the day of the wedding if you will be drinking alcohol. Take the metronidazole, just don't drink any alcohol, or it's okay to drink alcohol. So by show of hands, what would you recommend if the person asked you about this? How many would say A, don't take metronidazole the day of the wedding if you're going to be drinking alcohol? How about take metronidazole, don't drink alcohol? That's what our pharmacists will put on their pill bottle. They'll put a little martini glass with an X through it. So they will be counseled on that. How about it's okay to drink alcohol? Yeah, so I think C is probably fine and probably the right answer here. I mean, certainly if the person drinks alcohol to excess, they're going to have the same side effects they might have thought if they had a reaction. They're nausea, vomiting, abdominal pain, flushing. They're not going to feel good. But the dogma for years was that patients were advised to not drink alcohol when they're taking metronidazole because of concern for a disulfiram-like reaction between alcohol and metronidazole, or antabuse-like reaction, that very quickly when they took it, that they get nausea, vomiting, diaphoresis, they may drop their blood pressure, feel horrible, get very, very, very sick. This has been the standard warning given by physicians and pharmacists for years, and it appears as a contraindication in the prescribing information. It's pretty much been an accepted fact. Now, where did this come from? And pretty much it came from case reports. So case reports of this reaction, and people say, hey, I saw somebody, they came into the emergency room, they got so sick and they had all these symptoms just as described in this, but they referenced standard pharmacology textbooks from the 50s as this was an accepted fact, but we hadn't really been proven. Now, some of the case reports were very, very interesting. 4 of the 8 case reports were serious. There was one patient who died. The case report talked a lot about the interaction. The reason they died is that had a massive fall and they had a massive brain bleed, but they talked about it being a fatal reaction. They presumed this was the case, and in none of these did they have blood work that really showed that they had higher levels. They just were, the symptoms were there, this is happening. So here's where case reports don't always have the same requirement for data that we want to see. Here is the only randomized controlled study, 12 healthy participants, small placebo-controlled randomized trial. Where do you think you can get 12 healthy participants that want to be paid and want to get alcohol? Any ideas? Medical school. I'm from the University of Washington. I said it's WSU Medical School. But anyway, half of the study participants got metronidazole 3 times a day for 5 days. And that was really a good way to do it because some of the theories beyond a direct interaction are that the microbiota is changed and that may change and different bacteria can grow a little bit more. So I'm really glad that it wasn't, here's your dose of metronidazole, we'll give it to you, and then 2 hours later we'll give you alcohol when the metronidazole levels are high in the blood. So they did it right. They gave it to them for 5 days before. The other half got placebo. Everybody got the promised alcohol. So they got 0.4 kilograms per kilogram, blood testing done every 20 minutes for the next 4 hours. Blood was tested for alcohol concentrations and acetaldehyde levels to see if there was an interaction. They also measured blood pressure, pulse, skin temperature, and then a myriad of symptoms. They had a checklist of pretty much every symptom. Did they feel sweaty? Did they feel nausea? Did they feel queasy? Did they feel lightheaded? They had a whole checklist, and they found no difference between the patients who were on metronidazole and the people who were on placebo with the same blood alcohol and the same blood alcohol levels. A more recent study was a study that was from an emergency room, case-controlled, propensity-matched study, and I like this because they looked at blood alcohol concentrations, and they looked at sets of symptoms and what happened to people that had the same blood alcohol concentration with or without metronidazole. The people that were on metronidazole and came to the ER with high blood alcohol, and the people who weren't on metronidazole and came in with high blood alcohol. And not surprisingly, they didn't find a big difference. 36 patients in the study, 18 in the metronidazole group, 18 in the alcohol concentration match group. No difference in disulfiram-like effects between the two groups. No patients who received metronidazole had a detectable alcohol concentration, had a suspected disulfiram-like reaction documented. So we don't have a lot of data. We don't have a lot of data supporting this. We have that small study there. We have this small study. Interestingly, the CDC back in 2021, that's before the CDC went rogue. It's back when we used to respect the Center for Disease Control guidelines. They put in and removed the warning on metronidazole. The previous warning against simultaneous use of alcohol and metronidazole was based on lab experiments and individual case histories in which the reported reactions were equally likely to have been caused by alcohol alone or by adverse reactions to metronidazole. Metronidazole does not inhibit acetaldehyde dehydrogenase, as occurs with disulfiram, and the effects of alcohol by itself or metronidazole, which has pretty much the same sets of symptoms, may explain this, and that refraining from alcohol while using metronidazole or tinidazole is unnecessary. Okay, another really common one that we've been taught for a long time, 33-year-old woman cuts her finger on a glass jar. She goes to the ED and needs to have sutures on her right ring finger. What would you recommend for anesthesia to prepare for the repair? Would you give bupivacaine, 1% lidocaine, 1% lidocaine with epi, 2% lidocaine, or saline? So which of these should we do? How many want to do bupivacaine? How about 1% lidocaine? How about 1% lidocaine with epi? How about 2% lidocaine? How about saline? So kind of a mix, and people giving some kind of lidocaine, not many people picking saline. And a few people said lidocaine with epi, and lidocaine with epi is fine and probably is the preferred choice here. And I was certainly told, if you do that, you do not deserve to graduate from medical school. I was like, this is one of those, their fingers are going to fall off, their toes are going to fall off, and it's going to be your fault. It was one of those, this is an absolute, no questions asked. And, the thought here was because end arterial fields, you can get vasospasm, you can get ischemia, bad things will happen. And this has been in many, many emergency medicine textbooks, many, many other books. And how many of you were taught that? Yeah, a lot of you were taught that. I see some of the younger folks aren't raising their hands. That gives me hope for the future. So this is a randomized controlled small study, but 60 digital block procedures, 31 randomized to lidocaine with epi, 29 to lidocaine. Lidocaine with epi, 1 patient needed additional anesthesia. Lidocaine, 5 needed additional anesthesia. Digital tourniquet was needed in 9 of 31 patients with lidocaine with epi, and in 2/3 of those with lidocaine alone. So they had to induce ischemia with the digital tourniquet to get the bleeding to stop. That probably isn't great for people. 2 patients with complications after lidocaine, none after lidocaine with epi. Small study isn't going to change anybody's mind. So why don't we talk to the professionals? Why don't we talk to people who do this for a living, hand surgeons? So this is a study to look prospectively the incidence of digital infarction and phentolamine rescue in a large series of patients who had epinephrine in their fingers and hands. From 2002 to 2004, 9 hand surgeons prospectively recorded consecutive cases of finger epinephrine use, 3,100 consecutive cases of elective injection of low-dose epi in the hands and fingers, no cases of digital tissue loss. Phentolamine was never required, and this is the standard for hand surgeons. That's what they use. They kind of chuckle when they hear that people are scared of this, but this is what's been being used, and this was a study from many years ago, so this has been going on for a long time. I was giving this lecture about 10 years ago, and a podiatrist came up afterwards and said, you know, we've been doing that in toes forever, and he pointed me to this study from 1971, 18,000 patient records over 14 years reviewed, plus an additional 5,000 records from the author's practice spanning 27 years reviewed for foot surgery patients, all were deemed healthy. 65,000 digital surgical procedures reviewed that used lidocaine with epi, no complications due to epinephrine. So podiatrists use it, hand surgeons use it. I will say that these are healthy patients, individuals who have trouble with circulation to their hands, individuals with Raynaud's, individuals who have vascular problems already in their feet and hands. That is a different population. But the standard person who cuts their finger, otherwise healthy, there should be no reason to not use epinephrine. Question comes up I get from pediatricians, and they say, well, the other one that they talk about is avoiding it. No penile injections of this because this could be a problem there. And this is a review. No evidence found in literature for causal relationship between the use of epi as a vasoconstrictor and necrosis of the finger or penis. Studies and reviews show that the use of local anesthetics with epi on the fingers and penis is safe, with many clinical and economic benefits. Now, the problem I think people have with this, and I understand this, is that when something is still a standard of care, it may be a piss poor standard of care, but it's still a standard of care out in the community and everywhere, people are terrified that if they get the one-off random thing that happens, that there'll be all sorts of expert witnesses lined up. I was asked to review a medical record for a legal case on this, and it was a weird one. It was somebody who got an injection for warts with a Canada extract, and in the record it said that the person got lidocaine and Canada extract, and the lawsuit was they must have put epinephrine in there because this person ended up getting ischemia to the digit. And what I think she had was a low level vasculitis as a reaction to the Canada extract. It's used as a wart treatment. That's what I think happened, but their point was the doc just forgot to write that they gave them epinephrine. So it was easy to toss that one out because, well, epinephrine doesn't do this, so it doesn't, your whole pretense is dumb. But it does tell you that people are out there looking for this. And I know that makes people uncomfortable. And until the standard of care changes, people get very, very nervous about doing things even if it's not supported by the literature. So an old standard of care that's bad, people get anxious about doing something different. Okay, a few newer myths that are out there. These are ones that were, from a long time ago. An 80-year-old man with Alzheimer's disease is admitted to the hospital after a fall. He is noted to have coughing spells after drinking liquids. He has a swallowing study done which shows severe motility slowing in the esophagus. What do you recommend for him? So this person is having coughing spells after liquids, and his swallowing study is abnormal, has Alzheimer's disease. Feeding tube, thickened liquids, or continue with his regular current diet. So how many would recommend a feeding tube? Yeah, we really are not doing that for our patients with dementia. there isn't really a big mortality benefit and lots of problems. How about thickened liquids? How about regular diet? Yeah, many of you are saying current diet, which I think is the right answer. The standard has always been give this person thickened liquids if they're having coughing spells after drinking. That's always just the thickened liquids will make it easier. They'll know that they're swallowing it and they'll have less problems. And why do we care that much? What's a big deal of writing for thickened liquids? Well, thickened liquids have some negative effects: dehydration, poor oral intake, and worsening quality of life. If you actually write for thickened liquids in the hospital, they don't just give them things like milkshakes or things that you think are a little thicker. They actually put cellulose in it and things to make it truly thickened. And many of these things can be dehydrating, and they are just horrible. I mean, if you ever, years ago, back when I used to attend in the hospital, I used to make my residents and students take what they prescribe their patient. They give liquid potassium, you're all going to drink it. Nystatin swish and swallow, you're going to swish that for 5 minutes in your mouth and see how you like it. And thickened liquids, you're going to take a sip of this crap. It doesn't taste good, and you give somebody who's cognitively impaired, here's your liquid, you're going to take this stuff, they won't drink it. So there are some practical reasons for this, why this has come under fire. This is from a meta-analysis, from a few years ago. No convincing evidence that thickened liquid or texture-modified diets prevents death or pneumonia, nor improves quality of life, nutritional status, or oral intake in individuals with oropharyngeal dysphagia. There is need for further studies to look at optimal management. And then this study came out, got a lot of publicity, came out last year, a cohort study looking at patients 65 and older with Alzheimer's with suspicion of dysphagia. They were grouped according to whether they got 75% of their hospital diet consisted of thickened liquids or a thin liquid diet. And they really found pretty much no difference. Those who got thick liquids were less likely to be intubated, but they were more likely to have respiratory complications. So this is a group that generally you're not going to be moving to intubation on, generally. And they had more pulmonary problems. So they really didn't get a super benefit from this. Okay, a 65-year-old man with type 2 diabetes is admitted to the hospital for debridement of a diabetic foot ulcer. Has an extensive 5.4 by 6 centimeter ulcer on the plantar surface of the right foot with a purulent exudate and odor, and comes in and receives IV antibiotics. He has had progression of the ulcer despite oral antibiotics and weekly wound care. His meds are metformin, semaglutide, lisinopril, amlodipine, and atorvastatin. So you're admitting this person for a progressing diabetic foot ulcer. Blood pressure is okay, heart rate's okay, temperature's okay, labs, A1C 6.8, B121, creatinine 1.5 with creatinine clearance 45, and crits 36. So coming in to be hospitalized with a foot ulcer to get antibiotics, he's on, as you can see, semaglutide, metformin, lisinopril, amlodipine, and atorvastatin. What do we recommend for medication management for him? Stop his metformin. Stop his metformin, use insulin on a sliding scale as needed. Stop the metformin and semaglutide, use insulin on a sliding scale as needed. Stop metformin and semaglutide, start insulin glargine and mealtime insulin, or continue as metformin and semaglutide. So how many want to stop metformin? How about stop metformin and insulin sliding scale? How about stop metformin and semaglutide, use insulin sliding scale? How about stop metformin and semaglutide, start insulin glargine and mealtime insulin? How about continue as meds? Yeah, that's absolutely the right answer, but there has always been this push that when patients get hospitalized to get them off their metformin. And that has been studied. And not surprisingly, they do better if you keep them on their medications. I mean, there may be indications occasionally where you would not do that, but this patient's super stable. You all picked up on that. Has reasonable diabetes control. We don't want to mess the boat. And there certainly are big problems. I think nobody liked the sliding scale insulin. That's a disaster. All the studies with sliding scale insulin really show worse outcomes. And trying to figure out where sliding scale insulin came from, the best we could come up with was sometime back in the early 1950s. It was created by a rogue surgeon. So Yeah, but it's, I was taught that, and clearly we shouldn't be doing that anymore. Supplemental scale is very different when you give insulin around meals and you have it based on background insulin and you give a little extra insulin around meals. But just checking the blood sugar in the hospital and reacting with insulin, that's a myth from yesterday. Anyway, this study looked at continuing metformin for patients with type 2 diabetes was associated with a decreased risk for post-hospitalization, insulin prescriptions, and 90-day hypoglycemia, readmissions, and mortality. So when they didn't mess with that plan, patients actually did better. This is an interesting study looking at outcome of metformin continuation in patients getting contrast. Now, generally, that's one of the recommendations. People on metformin, if they're going to get contrast, they shouldn't be getting their metformin around the contrast, because what if the contrast shuts down their kidneys and they're on metformin, they're going to die, So this was an interesting study, metformin use in patients getting percutaneous interventions for ST segment elevation MIs, no increased risk of developing acute kidney injury in the patients who are receiving metformin, and no cases of lactic acidosis, no increase in rate of cardiogenic shock or death. So this is a group that standardly, historically, would have had their metformin stopped because they were getting contrast. They got their metformin, they looked at that, and they all did fine. A 59-year-old man presents with abdominal pain. He has a history of small bowel obstruction and diverticulitis. His medical history includes chronic kidney disease, baseline creatinine 1.8, hypertension, type 2 diabetes, and depression. He had a colectomy 6 years ago for colon cancer. He takes the following meds: semaglutide, 1 milligram weekly, amlodipine, 5 milligrams a day, escitalopram, 10 a day. On physical exam, blood pressure is 130/80, pulse is 90, and temperature is 37.2. Normal bowel sounds, but he's guarding in his right lower quadrant. Hemoglobin 13, hematocrit 39, white count 13.5, BUN 27, creatinine is 2. A KUB is unremarkable. What imaging do you recommend for him? The complicated patient who has this history of small bowel obstruction, diverticulitis, and also had colon cancer, and now has abdominal pain. CT without contrast, CT with contrast, an MRI, or an abdominal ultrasound. So how many want to get a non-contrast CT? How about CT with contrast? How about an MRI? How about an ultrasound? So most of you want to go with contrast CT, totally agree with you. And for many years, this patient, at least at my institution, I would have gotten callbacks saying we don't want to give contrast because the person has chronic kidney disease and we're nervous about that. And there is ample data now that this is something that we've been taught to be fearful of, but if it occurs, it is something quite rare. This is a study of patients with chronic kidney disease who received contrast, meta-analysis, 13 studies, 25,000, almost 26,000 patients. No increased risk of acute kidney injury in patients who got contrast compared to those who didn't get contrast. No difference in AKI in patients with diabetes or chronic kidney disease who got contrast. Another study that I really like is this ER study where they brought sick people into the hospital kind of at their worst. Almost 18,000 patients getting to the ET who had a CT with contrast, a CT with no contrast, or didn't get imaging, and they looked at their renal outcomes. Contrast administration was not associated with an increased incidence of AKI with an odds ratio of 0.96. So just looking at if they got contrast, didn't get contrast, they really didn't turn out to be anything different. A more recent study on this, retrospective observational cohort analysis of consecutive hospitalized patients over 18 who had AKI at time of arrival to ED, who did or did not receive intravenous contrast. The outcomes were persistent AKI at hospital discharge, initiation of dialysis at 180 days, almost 14,500 encounters. Contrast was given in 18% of those. AKI resolved prior to hospital discharge in almost 70%. No association between getting contrast and persistent AKI was observed. Among patients with pre-existing AKI, contrast administration was not associated with either persistent AKI hospital discharge or initiation of dialysis. So not saying it never can happen, and certainly we are much more cautious the more severe the CKD is, but this idea that we got to be terrified if people have any kidney disease about getting contrast, I think is getting into the myth realm. These two organizations that have a lot of skin in the game, I mean, the National Kidney Foundation cares about kidneys, and the radiologists are terrified of getting sued. So that combination, they're going to be very conservative. The risk of acute kidney injury developing in patients with reduced kidney function following exposure to IV iodinated contrast media has been overstated. You can give contrast if needed in patients with GFRs greater than 30. So they've really liberalized this, which is good. Okay, we're going to finish up with a couple of everyday myths. A 55-year-old patient of yours requests new prescriptions from you at a routine appointment. And this is as they're leaving. You've had a nice 25-minute appointment. It's now 45 minutes because you covered 8 different issues. And as they're leaving, they go, oh, by the way, I'm traveling internationally next month, and I want you to replace my emergency medicine kit. And this kit has azithromycin, loperamide, and oxycodone because they've all expired. What do? Replace the azithro, replace all 3 meds, tell them the meds should be fine. So how many want to replace the azithro? How about replace all 3 meds? How about tell them it should be fine? Yeah, that's the easiest way to have them get out the door. So yeah, and I have a bone to pick with these emergency medicine kits because I don't like to give meds to patients without talking about the risk benefit of it. And when I give a med, when I was giving kits out in the 90s, when that was such a big thing, I was giving out different drugs than I would give now, and they want them all refilled, and especially the oxycodone one. I mean, the person wants to hike Monte Picchu, and they're up at 1 billion feet, and they break their ankle. I do not want them popping oxycodone. I don't. There's just something about that seems weird. A little hypoxic, a little bit of oxycodone. What could go wrong? So anyway, so yes, the answer is drugs, especially pill forms, they don't really expire. And we're going to go through some data here, and especially PRN drugs. PRN drugs, certainly a drug that's super important for managing a disease that's a dangerous disease. They're never going to have like 25-year-old bottles of this stuff. They're generally taking it and refilling it. It really comes down to PRN meds, and it's remarkable how good they are. So what is an expiration date? Well, the expiration date is one that the manufacturer has to guarantee 90% potency. So they take it out to 18 months or whatever and say, yep, at 18 months, there's 90% potency. They don't extend it. They don't look at it a year beyond that, 10 years beyond that, 30 years beyond that. They just say, at 18 months, we guarantee potent. That's going to be our expiration date. So this is a study where they looked at all these drugs over 20 years old, and look at this. Except for ampicillin was only 92% and had 90% potency. All the others had 100%, more than 20 years after the expiration date. This is one where they found an old mom and pop pharmacy that had old crates in a back room for many, many years, 28 to 40 years past expiration date. Most of these were compound drugs, things like Fioricet, that have several different drugs in them. 12 of the 14 compounds tested were at concentrations 90% of the labeled amount. The only thing that really broke down was aspirin. Aspirin, they really couldn't find active aspirin. It broke down to less than 1%. But codeine, hydrocodone, acetaminophen, all those maintain their potency. I get a lot of questions about epinephrine because it's expensive. And several studies, original parenteral epinephrine, sterile and detectably pure more than 2.5 years after expiration. EpiPens less than 25 months past expiration contained at least 90% of the labeled active ingredient. And this study where they got healthcare professionals who had EpiPen juniors that had been just left everywhere, in their car, in their cabin, not climate controlled. 1 to 50 months past expiration, all had over 80% of the labeled epinephrine. Now, this is a high stakes one, and I certainly refill my patients' EpiPens, but I want them to have extra EpiPens because I want them to have EpiPens in every room of the house. I want them to have them within like 6 feet of them if they're going to anaphylax. I don't want them to have to go up to the attic and get their EpiPen. And so I tell them, you have your good EpiPen, that's the one you're going to keep as close to you as possible, but you can have the other EpiPens around if you've used your good EpiPen. If you can't find it, I'd rather have you have a bunch of EpiPens 3 years or more, within the expiration date than just to toss all of these. Now, albuterol is another one because people have inhalers, back since the Carter administration. You know, and people get these things, like I was in an ER one time, this was my met, and they want to know, could I still use it? Now, albuterol functions for long periods of time. This is a study, samples from expired lots of albuterol were analyzed for the levels of active ingredients. Manufacturer expiration dates range from March 2001 to April 2019. Nearly all lots of albuterol had over 90% of the listed strength over 15 years post-expiration. So most people that have a 30-year-old albuterol, it's probably not because they have horrendous asthma. They've probably gotten a new one. So sure, they can use their albuterol that's many, many years old if they can find it. The other question you get all the time is, will I die if I take an expired medicine? And the answer is, you know, if it wouldn't kill you the first time you took it, it probably isn't going to kill you now. So the only expired medication in pill form that's ever been reported is an old formulation of tetracycline that's been off the market since the early 1980s, and it was associated with four different case reports of Fanconi's syndrome, but no other meds have been reported, expired meds, to become toxic. I mean, the worst case scenario would be they'd be less effective if they lose their potency. As far as liquid formulations of things like eye drops, there are case reports of problems with eye drops because they can get contaminated. I looked again last night to see if there's anything new about eye drops because they're super, super pricey and people want to be able to use them longer. There just isn't enough data on eye drops. 29-year-old woman presents her evaluation. She reports she had frequent headaches over the last 12 months that include pressure pain on her forehead, under her eyes, and over her cheeks. She usually has nasal congestion as well. She has not had any fevers or purulent nasal discharge. What is the most likely problem? So frequent headaches over 12 months, pressure pain, forehead, under her eyes, over her cheeks, nasal congestion with these, no purulence, no fevers. What is the most likely problem? Cluster headaches, migraine headaches, sinus headaches, or tension headaches. So how many think these are cluster? How about migraine headache? How about sinus headaches? How about tension headaches? Okay, so kind of a mix. So this is a really, really common variant of migraine headache. And our patients will come in and say, I get sinus headaches. I get sinus headache 3 or 4 times a year. Give me a Z-Pak, give me some decongestants, I'll be fine in 2 days. Don't argue with me. I'm right. I know it. I've had this. I've had these headaches for years. So this has been really well studied, and these people respond unbelievably well to migraine-directed treatment. So this is a study of almost 3,000 patients screened who reported at least 6 headaches during the previous 6 months, self-diagnosed or physician-diagnosed as sinus headaches. 88% of these patients met International Headache Society criteria for migraine headache. Most common symptoms were sinus pressure in 84%, sinus pain in 82%, and nasal congestion in 63%. So this variant is different in that it doesn't have to be unilateral. We usually think of problems with migraines as being unilateral headache. In this variant, these patients can get bilateral symptoms as seen in this study. 100 patients recruited who believed they had sinus headaches all had a detailed history and physical exam and given headache diagnosis based on International Headache Society criteria. Final diagnosis, again, about 85% of them met migraine criteria, migraine with or without oral, probable migraine, chronic migraine with medication overuse. 76% of the migraine patients reported pain in the distribution of the second division of the trigeminal nerve, and 62% had bilateral forehead and maxillary pain with their headaches. This is a study looking at 1,679 patients with migraine without aura. 60% reported 1 or more rhinologic symptoms during attacks, and 20% had symptoms that met clinical criteria for rhinosinusitis during their migraine attacks, including 50% facial tenderness, 13% decreased smell, 20% unpleasant smells. So this is a migraine symptom. I love this study. This is sort of real life. So they recruited 54 patients to do these studies. So they were going to do nasal endoscopy, they were going to do CT scans, make sure their sinuses look pristine before telling them that they had migraine. So they recruited these people who said they had sinus headaches, these hardcore sinus headache people. 54 enrolled, only 38 completed. And the reason is that 16 of those patients, when they were told their sinuses looked fine and they had normal nasal endoscopy, left the study and said, you folks are crazy. I'm going to go to doctors that aren't nuts because I have sinus disease. So they left the study because they didn't believe the information. I know you don't see anybody like that in Wisconsin. We do see them in Seattle sometimes. So anyway, of the brave 38, 31 of them, 82% responded really well to triptan use. Total of 92% responded to full migraine-directed therapy. If they didn't respond to triptan, they got other migraine-directed therapy. So almost 9 out of 10 responded. So this is something to try in your patients who say they get recurrent sinus headaches. The reason they get better with the azithro and the decongestant is migraines last for a day, maybe a day and a half. So they take the meds, the next day they feel better, they are certain it works. Okay, a 59-year-old is admitted with abdominal pain. She has a history of pancreatitis. Contrast CT scan is ordered. She reports a history of severe shellfish allergy and an allergy to betadine when the radiology tech asked, as she is checked in for the procedure, you are paged with regarding what to do. So continue with the scan as ordered, switch to an MRI, switch to MRI with the gadolinium, continue with CT with contrast, give dose of solumetrol, continue with CT with contrast, giving IV diphenhydramine. So you're called because this patient has a severe shellfish allergy and a betadine allergy when quizzed by the radiology tech. So how many would say continue with the scan as ordered? How about switch to an MRI? How about switch to MRI with gadolinium? How about go ahead with the scan, give solumetrol? How about continue with CT scan and give IV diphenhydramine? So a lot of people are nervous here. There's nobody's, a couple of queen waves, but other than that, everybody's like, ah. So I think the right answer here is A. Just, hey, I ordered the scan, go ahead and do it. And where does this come from? Well, fish and shellfish contain iodine, and allergic reactions to seafood are quite common, with a prevalence ranging anywhere from 2 to 6% of the population. And the idea is, well, iodinated contrast, these foods have iodine, cross over, I'm going to have a much greater chance of having a problem in this patient because of that. Now, the problem with this is, first of all, iodine is present in most of our foods, many of our foods, milk, bread, yogurt, iodized salt. We don't ask people about that. But more importantly is the allergy of shellfish has nothing to do with iodine. Nothing. It has something to do with a couple of different proteins, paralbumin and tropomycin. So it has nothing to do with iodine. So worrying about that doesn't make a lot of sense. How widespread is this belief? Well, it's pretty widespread. A questionnaire formulated and distributed to hospital doctors in 4 tertiary centers. They were presented with 6 different scenarios of bona fide allergy to iodinated substances and asked to select treatment response, which they deemed to be most suitable. Standard contrast scan, delay scan with pre-medication, or change to a non-contrast scan. 87 questionnaire responses were received. Contrast, standard protocol, was the appropriate regimen in the setting of all listed allergies. This was identified correctly for 76% of people who had a kiwi allergy, 69% of fish allergy, 44% of polyfood, 32% of shellfish, 18% of betadine, and 14% of tincture of iodine. So the more you said the word iodine, they were like, no, no, no. But shellfish, everybody went, well, yeah, that's an iodine one too, and it isn't. Why is this? What happens here? So bottom line is contrast reactions occur in 6 to 15% of people who have seafood allergy, but 14% of people who have milk, eggs, chocolate allergy, 13% of people who have general allergies, 13% who have fruit allergies, and 11% of people with asthma. So people who are atopic, people who are allergic are more likely to be allergic to something else. Makes total sense. The craziness about asking about seafood allergy is unless you ask about all allergies and are worried about that and make a decision on that, it makes no sense to single out seafood allergies. And the standard thing to do, and the current guidelines are, go ahead and treat these people. If a person has a reaction, then we pre-treat them the next time. That's when we give them the pre-treatment. We don't pre-treat people we think might have it. So the American Academy of Allergy Asthma and Immunology doesn't recommend lower isoosmolar radiocontrast media or pretreatment with steroids and antihistamines for people with seafood allergy who require radiocontrast media. The American College of Radiology recommends pretreatment with steroids only for those who have a previously experienced moderate to severe reaction to IV contrast. And betadine, it's the same thing. Betadine allergies treated the same way. They are not, we do not pre-treat them, and we do not give them contrast. Okay, I'm going to finish up with colonoscopy dogma. Some of you have probably had a colonoscopy, and you know, the dogma was always clear liquid diet for 1 to 2 days before colonoscopy, a gallon of Go Lightly, and be absolutely miserable. And that the problem is then now you have to tell them in the future to do it again. So we want to make it as easy as experience so that my patients, I don't have to spend a half hour telling them they need to get another one when they've found polyps. So this is just a standard. My institution still has this ridiculous dogma. So the first thing is, can you let them eat? And the answer is yes. And if you let people eat and not be on clear liquid diet, they're going to be happier. Study 200 patients randomized to low residual diet versus clear liquid diet. Low residual diet allowed meat, eggs, dairy, bread, rice, so people can find something that they're fine with eating throughout the day before colonoscopy. The patients in the low residual diet group had better bowel prep than those in the clear liquid diet group, 81 versus 52%, less nausea, vomiting, headache, weakness, and hunger, and less anger. This is a meta-analysis of low residual diet versus clear liquid diet, comparable in regards to adequacy of bowel prep detection for polyps, less nausea, vomiting, hunger, headache. Patients who followed low residual diets showed an increased willingness to repeat it compared to those who followed clear liquid diet. Not a surprise. So people can eat through dinner time with a low residual diet the day before. How about bowel preps? And the answer is Go Lightly is the worst choice. It's a lot and it doesn't work as well because most people don't complete it. So the lower volume bowel prep, Sue prep, movie prep, Miralax plus Gatorade combination, all were superior for bowel cleansing. And the patients who took these were much more likely to complete it because they didn't have to drink a massive amount of stuff they didn't like. Now, I was so excited to see in the most recent guidelines, they finally put it in the guidelines. For most average risk patients, dietary restrictions need to begin no sooner than the day before. Diets as part of the split dose regimen should be clear liquid or low fiber, low residue diets. So they put in the low fiber, low residue diets. They just need to get with the game and let people have it for dinner too. Maybe the next guidelines will do that. 2 liter versus 4 liter preps now is suggested for ambulatory patients at low risk for inadequate prep. So they're saying you can use the low volume and it's only in people that have really slow motility do you abuse them. So bottom line is they can eat, low residual diets are tolerable, Go Lightly is really a relic of the past, all it has going is low cost. And then the last thing I'm going to do is just a quick lightning round here of just a bunch of my favorite myths and one-liners that maybe you've heard about. Seeds and nuts do not need to be avoided in patients with diverticular disease. You do not need to avoid blood pressure checks or blood draws on the ipsilateral side of people who've had breast cancer surgery. Testing for folate is very, very, very low yield in anemia workups. You can orally replace vitamin B12 in patients with pernicious anemia, and it's as good as injecting it. And you do not need to give antibiotic prophylaxis before dental surgery in patients with artificial joints. And the last one is Colace does not work at all. It is ridiculous, and why anybody prescribes that is beyond me. Okay, I am done with this. I'm happy. Thank you. If there are any questions or comments people have.
Yeah, I think we'll have time for one question from the audience. Okay. While we're getting the...
Thank you. Great presentation, Rod Castillo, GI. Thank you for putting the colonoscopy in the picture there. So just one question. The metronidazole dose used in that study was 500 milligrams 3 times a day, 7 for 5 days.
500 3 times a day. Yeah.
Okay. And the other question I had means I really appreciate the comment on colonoscopy. Definitely a smaller, easier prep is usually better tolerated by patients. It can be customized to the patient's need. Sometimes the issue with colonoscopy prep is confusion. So that's why we want to keep a clean slate for the majority of patients to avoid confusion. But yeah, great talk. Thank you so much.
Thank you.
All right, Doug, one of the traditions is you get to draw for the winner. Dun, 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 dun.
Okay, we read this.
Let's see. Oh, James Llewellyn. Where is James? Well, we'll give it to James, and we actually have one or two more thanks to Shikra. Dun, 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 dun.
Okay. Mike's.
Oh, Mike. Yes. Excellent. Good enough. And one more. Dun, 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 dun.
Ahmed El.
Oh, Ahmed. Repeat winner.
Oh, yeah.
Excellent. And then to thank you, where is our, oh, yes, we have one of the
Oh,
prints,
wonderful.
as well as, just as a reminder, when you go back to Seattle, we have our traditional miniature memorial chair from the terrace in Wisconsin red, not husky purple. So thank you.
Thank you.